Okay, good morning, everyone. Let's get started. We're going to talk about polyps today. So this is all the topic. It seems a lot, but I think we, we usually see the first five in our daily practice, and then the last two maybe not that common. So here's the table in Sternberg. That's really nice. So I don't want to go through any of these details. I just highlight some stuff. First, hyperplastic polyps, they divide into two subtypes. One is microvesicular, the other one is goblet cell rich. I don't think in sign out we will put this kind of description there. But it seems these two subtypes is related to different mutation. The microvesicular is related to BRAF, and then the goblet cell rich is related to KRAS. Then we have our SSP, serrated polyp, and serrated polyps with dysplasia. So, or we can call it SSP, SSA, and SSL. That depends on which one you prefer. Then for this SSP, related to BRAF mutation, and also related to CPG island methylation, especially the one with dysplasia. And then the last one is a TSA, traditional serrated adenoma. For these two mutation, kind of really the percentage quite similar, but more likely to see in KRAS. So the first one is the microvesicular hyperplastic polyps. I put here this hyperplastic polyp usually in the left column. So low power, we can see the surface is kind of serrated in the surface, and then the crypt kind of like funnel shape. They just going out. The outer part is wider than the deeper part, so there's a funnel shaped crypt. Then we do not see any any hyperchromasia and other stuff. Then this is the high power to show this microvesicular type. We have some goblet cell, but between this goblet cell, we have these tiny vacuole. So this is called a microvesicular type of the hyperplastic polyp. Then if we have this horizontal section, we can also see this stellate star-shaped crypt with the characteristic for this hyperplastic polyps. And then we can see some goblet cell, but between the goblet cell, we can see this microvesicular. Then if the polyps get injured, they will lose most of this most of this mucin. You could not see any goblet cell, but still a hyperplastic polyp. Then sometimes the hyperplastic polyp, they have some nucleus like merged together, so forming like these viral cytopathic changes. But when you do the immunostaining, these are negative. Then sometimes they also can, in the polyps surface, you also can see this thickened basement membrane, but this is not collagenous colitis. This is just polyps. This is normal phenomenon. You can see the hyperplastic polyps. Then usually the hyperplastic polyp, you can also see this displacement of mucosa elements. So the surface of the polyp just invaginate inside. And how could we tell this invagination from high power? We can see several features. First, we can see hemorrhage, and then we can see hemosiderin deposition. Then we also can see prominent vascular mucosa. So combine these three features, most likely this is just a displacement of the mucosa invagination into the deep of the polyp. Then we have these goblet cell rich hyperplastic polyps, also serrated surface, but for this type, we can see a lot of goblet cell. And then high power, we also can see a lot of goblet cell, and then the crypt a little bit dilated. Then we move to another topic. I think the right column, because sessile serrated polyp usually in the right column. So only one feature is important for us to make the diagnosis. Of course, the surface, we also can have this serrated surface, just like hyperplastic polyp. But one characteristic feature to make diagnosis is this dilated grip, and all the way down from the surface to the muscular mucosa. So this line is dilated, kind of like bush shape, some people say. So this is the only feature we want to see if you want to call this serrated polyp. Another picture, we can see this dilated grip go all the way down. This is the high power to show this dilated. And I think from one of the lecture from Dr. Li before, and as well as the unknown, we can see a adenoma, maybe in the polyps, and then here I think this is kind of that feature, the stroma perforation forming a circumferential curve around the crib. So, and then when you do immunostaining, you will see EMA positive or even positive for GOT1. So just like the perineal cells immunostaining in this SSP. Then here's the serrated polyp with dysplasia. So we can see really well transition, abrupt transition here. Here we can see hyperchromasia, loss of the goblet cell, pseudo-stratification of all the nucleus, really cloud here, and here is the one without dysplasia. So we know this is a serrated polyp with dysplasia. This is the high power to show this plastic grip here. Then we have another picture. This is the normal SSP, and then this area abrupt transition to this hyperchromasia, clouded grip. So this is the SSP with dysplasia. This is a high power to show really dark nucleus, and then really cloud here, loss of all the goblet cell. We have some apoptotic and even some mitosis. Then move to the other topic. Here's a TSA, traditional serrated adenoma. So this one is usually seen in the sigmoid and rectum. So in low power, we can see this villous projection lined by this serrated epithelium. And then in low power, we already noticed that the color is really pink, not blue, not purple for this entity. So when you see low power, the polyps looks really pink. You need to raise your suspicion whether it is a TSA. Then high power, we can see this pencil-lated nuclear and columnar with abundant eosinophilic cytoplasm. So that's the reason low power we can feel the pink color. And then for me, the characteristic feature for me to call this diagnosis, that is the ectopic grip. So just usually in the surface, you can just have this epithelium, but in this entity, you will see they forming some grip in the surface. This one is more obvious. We can see the grip going up to the epithelium surface. I think this is the most useful feature for me to call this diagnosis. We can go back to this table again. So we just need to remember, I highlight some of the stuff, like I mentioned before, so I don't want to repeat that. So just focus on the BRAF and KRAS, which polyps are maybe more related to which mutation. I think maybe in examination, they will ask us. And usually I won't pay attention to this in daily sign out because we just focus on the diagnosis usually. Then we have next entity, this Peutz-Jeghers Polyposis Syndrome. And this syndrome always affects the small intestine. But more than 50% of the patient also have lesion in the stomach, colorectum, or even the appendix. The mutation related to this syndrome is STK11 tumor suppressor located in chromosome 19p. So here's the picture to show what is this Peutz-Jeghers syndrome other than the polyps in the small intestine. They can have all different kinds of GI tract malignancy, and also breast carcinoma, this GYN stuff, and also male testicle carcinoma. And then in the cutaneous surface, we can see this pigmentation in the lip. In the colonoscopy, you can see this multinodular with a thick stalk of this polyp. Then the microscopic feature, we can see these arborizing bundles of smooth muscle because these polyps fall into the hamartoma category. So we will either see different kind of mesenchymal component in a hamartoma. So in this Peutz-Jeghers polyps, we can see this aberration, smooth muscle. Then we also can see lamella propria to support all of this epithelium in this polyps. Sometimes we see a cellular mucin pool in the musculary propria in this polyp, but not mean this is carcinoma. Then, and then in these polyps, we can see this brown-forming blind lobula of this crypt. This is one of the characteristic features for this Peutz-Jeghers polyps, because sometimes we will have other type of polyps that we talk about later, like the juvenile, and then also the Cowden Syndrome polyp. They are also falling into this hematomatous polyps. They also have this small muscle arborization into the polyps, but they do not form this well-formed lobular structure. But sometimes they just looks quite similar. Not easy to tell the difference in the microscope. So for the Cowden syndrome hamartoma polyp, formerly termed P10 hamartoma tumor syndrome. So most of these patients with germline P10 mutation, but some patients, if they without P10 mutation, they will have this SDHB or SDHD mutation. So this is the diagnostic criteria for the Cowden syndrome. From the Sternberg, you can go through it by yourself, see what is the major criteria and the minor criteria. So from the colonoscopy, you can see one sessile nodule in the gut. Then we have this spindle cell proliferation in the stroma. Sometimes we also can see ganglion cell. So they're forming this ganglion neuromatous element. So we have spindle component. We also have ganglion cell components. And then as a hamartoma I mentioned before, we can have other mesenchymal parts of the tissue. Like this one, we not only just have spindle cell, we also have mature fat in the polyp. This is intramucosal lipomas. So in the Cowden syndrome, we also can see this lipoma into our lamella propria. And then, of course, a strong S100 positive for this adipocyte. And also, we can see lymphoid polyp in Cowden syndrome. So just the lymphoid aggregate, but they just shrink out just like polyp. So we also can see this. Then, as I mentioned before, we have a different kind of hamartoma syndrome. We have juvenile polyps, Peutz-Jeghers. We also have mucosal polyps because all of these polyps have this small muscular mucosal growth into the polyp. So just like one of the features of the polyps. And here is the juvenile polyps. I think other people will cover this topic, so I just briefly show the image here. We have stromal expansion, cystic dilated crypt, and then kind of the matters of the stromal kind of pale, and then we also have inflamed, different kind of inflammatory cell, and this kind of hemorrhage. So this is juvenile polyp. And then sometimes in the Cowden hamartoma syndrome polyps, you also can see this dilated crypt. So kind of identical to the juvenile polyps, so you just cannot tell. Then we have Peutz-Jeghers polyps. From the right side, this is the Peutz-Jeghers polyps. As I mentioned, in this power seems these two juvenile polyps and Peutz-Jeghers polyps look quite similar because both of them had prominent small muscle proliferation into the polyps. But as I mentioned before, Peutz-Jeghers, they form this well-formed lobular structure of all the polyps compared to the juvenile. For the juvenile, they do not form this well-formed lobular structure, just randomly distributed of this crypt didn't form this structure. Maybe this is helpful to tell the difference. Then I have some virtual slides. We can go for it quickly. So here's the first one, sessile serrated polyps. Let's go to one level. You don't need to go so high power. So here we already see this dilated crypt from the surface all the way down to the muscular mucosa. So even from this feature, and then we can make the diagnosis of SSP. For this one, we see the color is really pink compared to we usually see the TA that's really bluish and purplish. So I didn't know this is a pink polyp. Then even in this power, we can see in the surface we have this ectopic crypt. Really characteristic feature for traditional serrated polyps. Then we can see some of the nuclear feature, the pencilated nucleus. Here, really elongated nucleus abundant eosinophilic cytoplasm ectopic crypt. So this one is good for TSA. This is the Peutz-Jeghers. We can see this muscular mucosal growth into the polyps, this small muscle proliferation. Then with all of this crypt forming this well demarcated lobular structure of the crypt. So this is the characteristic of the Peutz-Jeghers polyp. We have another one, Peutz-Jeghers, But when we see this smooth muscle cell growth into the polyps and then this lobular structure, we can this is suspicious for this Peutz-Jeghers polyps. We have one more same feature, this smooth muscle growth into the polyps and then well-formed lobula of the crypt. Then this is the juvenile polyps. You can see the polyps kind of inflamed and hemorrhagic, and the stroma kind of pale because of edematous, and then also we have this dilated crypt. So this is the juvenile polyps. I think that's all.